Okay, so I I guess one of the biggest challenges of dealing with adverse effects in systematic reviews is that it it sometimes looks like a complete mess. You don't know where to start and no idea where to find the data. So I'll spend the first 10 or 15 minutes uh, just explaining how to make some sort of order out of it and how to perhaps focus down the task. Otherwise, you could get lost very easily. And after that, Sue will take over and deal with the difficult bits of actually conducting a search, which can prove extremely tricky. Now, just got some nice nice photos of ourselves. Obviously, mine was taken several years ago, so I bear no resemblance to that person there. So how do we end up in a situation where we're trying to assess adverse effects? Well, we consider that a Cochrane review that looks only at the benefits or the favorable outcomes would present a biased viewpoint, unless it also explicitly looked at what kind of harm or adverse effects could arise during the intervention. Because obviously everything that we do in healthcare, for example, there are unintended consequences to it, and these should be fully considered when we're discussing or planning treatments. So I guess this is the biggest challenge of them all. If you think about beneficial outcomes, you probably look at two or three important benefits, typically measured as primary outcomes. However, when you look at adverse events, there are hundreds or even thousands of them, because anything that can go wrong will go wrong in a trial. And therefore, a huge, diverse range of adverse events are captured and reported. And because of this overwhelming information overload, you will find that the case definitions for adverse events are not well standardized. It's very hard to write up the adverse events in any detail, and sometimes you don't even get the numbers of adverse events in the trial report. You might just get a very brief summary. And by far the biggest problem is what I mentioned at the bottom of this slide. So because there are hundreds or even thousands of adverse events, only a small fraction of them are actually reported in trial publications, according to the whims and fancies of the authors, the reviewer, or the editor. So it's a huge amount of selection bias occurring in terms of which adverse effects are reported in the trial, and everybody might choose to report a different set. Now, one of the things that might help you is that depending on the intervention, some adverse events can be defined and pre-specified in the protocol as adverse events that are a primary or secondary outcome, or they could be adverse events of special interest. And these could be prospectively monitored and captured. So if you know that that a drug knocks out your platelets and you're more likely to bleed, then the trial could measure bleeding. If a drug is used in diabetes and it causes low blood sugar, then you could measure how many people suffer from low blood sugar. So if you know the intervention reasonably well, you can pre-specify and define adverse events that should be monitored. And that helps you narrow down the list a little bit. The qualifiers for this, well, for new drugs, it's impossible for us to predict or to set up formal measurement systems that can pick up unexpected or complete out of the blue adverse effects. And so what happens in that situation is that the trialist or the systematic reviewer ends up doing a look back. And the trouble with any look back is that you're doing a retrospective evaluation of unexpected or unanticipated events where you don't necessarily have a clear case definition or a clear way of monitoring and reporting it. So we're often caught in this thing where we're trying to look back at things that have already happened. So I won't spend too long on the review question, but for adverse events, I have a few tricky bits to think about. So I've done an aspirin review before. Gosh, that was in previous lifetime. But you know, which patients should we have in this aspirin review? We wanted to look at bleeding with aspirin because it knocks out platelets, and we found aspirin used in all sorts of different conditions: heart conditions, strokes, arthritis, headaches, whatever. So do we just choose the heart condition or the strokes or the whatever? Because it may have different adverse effects depending on which condition you're using it in. And so do we look at aspirin, soluble aspirin? Do we look at capsule aspirin or enteric coated aspirin? So interventions come in different fashions. And challenges that we always find, if we take the drug against placebo, for instance, that would be the cleanest possible study, scientifically valid, but patients don't take placebo in their real life. So it makes interpretation of adverse events slightly different if you're considering that patients are actually on a variety of different active drugs. And outcome, as we already discussed, it's relatively more straightforward to look at well-defined adverse reactions that that you've identified from the way the intervention works, but it's hard to look back at potential ones. And I'll talk about study designs because it's one of the few times that you might want to deviate from just the RCT alone. So how do we decide what study designs to choose when we do the search? Well, it helps to know about the adverse effects that you're looking for. So we encourage people to define one or more adverse effects as of special interest or critical or important outcomes in the protocol. And if you like, you could have an exploratory element instead, where you extract any or all of the adverse events data found within the selected studies. And that's what I call a wide or broad sweep, which has its challenges. Most people have a hybrid approach, and they specify one or two key adverse effects, and then they'll have a look around to see if there's anything unexpected that pops up in the trial reports. How does this work? So, for instance, in my aspirin review or non-steroidal reviews, you can say, I'll do a confirmatory targeted approach at bleeding from peptic ulcers or stomach ulcers. If you're doing a review on exercise interventions in frail elderly people, then you could say, well, I'm worried that they will have fall and they'll break a leg. So you can look for falls and fractures as a pre-specified example. So if you're doing a tonsillectomy, then you can look for bleeding infections in surgical cases. So that's the confirmatory approach. What about exploratory then? So we have done a review of dexamethasone and tonsillectomy where they measured all adverse events as well. And in fact, it became a hybrid review where they had two pre-specified ones, and then you have a broad sweep version. So which one do I recommend? Well, the confirmatory approach where you have pre-specified, let's say, two adverse events of interest, then it's efficient, targeted, and you could agree it beforehand with your review team, and you have set up your data extraction sheet to look at those events. You can't always match that though, because you need to know what are the relevant ones. people might say, well, we only covered one or two events. We didn't manage to look at the new or unexpected events. And we're still reliant on people reporting the events that we're interested in. And this is, of course, is a danger. You might find nothing if you only look for two or three adverse events. So difficult decisions to make on these things. So if you're worried about finding nothing, then you could do an exploratory approach where you say, I'm just going to capture everything that's been reported by the research investigators. And this may include new unexpected events. And you have a very comprehensive extraction there. That's every bit of reported data that's in the trial report, for instance. On the right side here, I've got concerns about this, that as I mentioned at the beginning, there's a substantial amount of selective outcome reporting going on. Of the hundreds of adverse effects, why were 10 of them chosen to be in the table in the trial publication? And we don't know. We can't really work out how they were chosen to be in that table. Were they chosen based on clinical importance? Chosen based on statistical significance? It's hard to tell. So you may have a long and a disparate list where every different group of trial investigators have reported different things, inconsistent case definitions, as we know. And for me, each time I face this, I have a nightmare to pull or to interpret and summarize these findings with the exploratory approach, where we have downloaded long list of adverse events from different trials. Okay, so that's the first starting point. Define your adverse effects of interest, and then choose the study design that could answer the question. And some of the things you need to know is that, is this something that occurs soon after starting the intervention? Or is it something that occurs 5 years down the line? Is it something to have a low or high incidence? What's the background rate? Is it easily detected or measured? I'm not spend too long on bias here because it's not really a talk about bias, but we've got to be conscious that we can have problems with false positives and false negatives with adverse effects reviews. Type 2, because your sample size is too small or the monitoring was poor. Type 1, possibly because of selective reporting of significant findings or multiple testing, for instance. So if you have some idea what your adverse effect of interest is, and I've said, let's think about something that occurs soon after starting the intervention. It's got a relatively common background incidence and a higher, highly increased risk with the intervention, then RCTs would be suitable for giving you data on this particular adverse effect. If the risk increase is small, maybe you need a very large RCT or meta-analysis of small RCTs. Reasons for this is that because RCTs can often pick up things that have a short exposure and occur commonly, you got a good chance of finding it. This slide shows the more difficult scenario. It's something that something harmful occurring 3 years down the line after receiving your intervention. It's rare. Okay, even if the relative risk increase is great, you may need lots of large long-term RCTs or non-randomized studies. And when you're into a rare long-term adverse event that takes 4 or 5 years to occur, then you may have to pull data from several non-randomized studies, particularly for unexpected and unknown ones, where you are always having to try and look back and see if anybody picked it up. So I guess this is my last slide. Whenever I'm faced with the question, what's the best data source we should use? I think you should choose the one that answers your question. We've done reviews where we've been trying to measure things like cancer, adverse events, and so on. And if you got several short-term RCTs that are only 3 months, 6 months, or 1 year, you could pull all the data together and you end up with nothing. So I would suggest that when you define your adverse effect of interest, you should also think of what sort of research studies are likely to be able to accurately define and measure that particular adverse event. I'm going to stop sharing so that Sue can take over. Okay.
Hey, thank you, Yoon. So I'm going to be talking now about assuming that you've decided what you're searching for, what study designs, and what adverse events you're searching for, looking about how you search and where you search. So I don't mean to be negative, but there are some special issues with searching for harms. I think Yoon's already touched on this indirectly. So there's poor reporting in the titles, abstracts, and the indexing. And this is largely because adverse events or harms are a secondary outcome or even tertiary outcome, and so don't always make it into the title and abstract. There can also be a small part of the overall full text article, and therefore not make the indexing either. There's also a lot of inconsistent terminology and inconsistent indexing. I think this is largely that there's so many terms that you can use. So already I've used harms and adverse events, and I've only been talking for a few seconds. But there's also side effects, there's complications, unexpected event, you know, all sorts of terms there. And again, with the indexing, there's a lot of different indexing terms that are applicable for adverse events. And as you already stated, you may wish to identify all harms. And obviously, it's really hard to search for what you don't know you're searching for. So at the beginning of the systematic review, you might not know which harms you should be searching for, especially if you want to identify unexpected harms. And then there's the range of study designs. We have great filters for searching for RCTs now, but searching for other types of study design is a lot harder to do in a sensitive manner. So it's really hard to go beyond RCTs without being inundated. So I've often been asked whether you can use the same search that you use for your benefits or effectiveness question. And the answer in most cases is no. A single search doesn't often work, so I generally don't recommend it. Partly because of the study designs, you often go beyond RCTs for the harms data. As already mentioned by Yoon with the great example of aspirin, you might not be limiting to a particular condition, which you would do if you were looking at effectiveness. So it's often that you need separate searches. The only time I can ever remember doing just a single search was where it was a very new drug and there was so little studies that we just searched for the drug terms and that was all. There was no need to put any filters on. We just got a manageable number. But I think that is very rare. So the sources you need to search is it's a bit like the effectiveness or benefits search in that I'm afraid there's no one-stop shop, and MEDLINE doesn't find all the articles for you. There's lots of studies. I've done a couple of case studies where I've looked to see which data sources found adverse events data, and they were in a range of databases, and you needed at least there was 5 or 6 in each case study that needed to be searched in order to retrieve all the papers. So I'm afraid there's a wide breadth of sources that you need to search. In particular with adverse events data, there's a lot more in the unpublished sources. And I think this is largely, as Yoon touched upon, that you can have hundreds or even thousands of adverse events, and there's so much data, and they're secondary outcomes. So they're not often put into the journal article where you've got a word limit of, say, 3,000 words. So with harms data, it's sometimes good to include unpublished sources like clinical study reports. However, they can be very still difficult or slow to get hold of. and quite cumbersome to go through. Trials registries are a lot easier to search and get hold of data that's in trials registries, although some trials authors are quite slow to put the data in, even though they shouldn't be. And then there's regulatory agency websites that also can provide data. It tends to be case reports of adverse events, however, so also you've got to be careful there where you've not got a numerator and denominator. So Yoon's already mentioned the PICO for the planning the search. So what I find when I'm doing my effectiveness searches or my benefit search is that I often search for the P and the I. But when I'm doing my harm searches, I often search for the I and the O, with the O being the outcome. Obviously, the I, the intervention or the exposure, you would search in the normal way. But the outcomes, the harms, I think there's a slightly different approach. So because for outcomes, we've got our specific terms for the harms, such as headache, cancer, death, etc. And these can be searched in the title and the abstract as text words, or they can be searched as indexing terms, for example, MESH in MEDLINE or M-Tree in Embase. But then you've also got the generic terms for harms, such as your adverse effects, your side effects, obviously harms, complications, etc. And these also can be searched as text words, for example, in the title and abstract, and as indexing terms in the MESH and M-Tree, for example. But they can also be searched as subheadings or qualifiers. And there are some search filters or search hedges, whichever terminology you like to use, to help you search on generic adverse events terms. So if I look at an example record here, you can see that we've got, it can be picked up in the title by adverse events as a text words or a title search. And it can also be picked up by the MESH subject heading adverse drug reaction reporting system. But it also has the subheading adverse effects, which is represented by the AE. So there's lots of free text terms that you can use, which I started to mention. So lots of different synonyms that you can use for your text word searching, for looking in for example, the title and an abstract. So I've just listed quite a few here, but do be careful, because terms like risk would find relative risk and risk of bias. So I tend not to use it very often. Harm brings about lots on self-harm and so forth. And safety a lot on the more larger topic of patient safety. And then I still get papers saying adverse effects were not considered, or adverse events were not considered, or we didn't find any adverse events. So I mentioned that there's quite a lot of inconsistent indexing and lots of indexing terms available to you. And indeed there are. So that this is for MESH. So this is for MEDLINE or Cochrane and other databases that use MESH. And the indexing terms you use are very highly dependent on the type of intervention you've got. So if you're searching for adverse drug events, that's very different terms. So you've got your drug recalls, drug monitoring, drug-related side effects, safety-based drug withdrawal terms. Whereas for a device, it's very different indexing terms: equipment containment, equipment failure, equipment safety, etc., and medical device recalls. Whereas surgical complications or adverse or harmful outcomes from surgery, you're looking at more complication terms, such as post-operative complications. And product surveillance post-marketing covers both drug and device. So lots of different terms, I'm afraid. No one-stop shop to search, and no one indexing term. The same goes for Emtree. It's not just MESH, where we've got lots of different terms, and they are very dependent on the type of intervention. So again, different terms for if you've got a drug intervention that you're looking at the harms for, or whether it's surgery or a device. I mentioned subheadings in passing, but I'd like to just expand on that a little bit further, as I think subheadings are really key to searching for adverse events. I very rarely use them outside of the adverse event arena, but I always use them when searching for harms. So these are the subheadings that I would recommend trying in MEDLINE and in Embase. Adverse effects or adverse drug reaction or adverse device effect being the most relevant. And there's ways, particular ways that you can search for with subheadings. So one way is to attach it to a indexing term, and this can be either the intervention itself. So I've got aspirin AE in MEDLINE, and that is finding aspirin when it is attached to adverse effects as the subheading. So they're both got to be together, so they come as a package. But you can also attach the attach a subheading to the adverse effect. So here I've got headache chemically induced in MEDLINE, or headache SI, which is side effect, in Emtree. So that's how you use them when they're attached. But very cleverly in some databases, for example, Ovid, you can float your subheadings, which means they could be attached to any indexing term. And this is a much more sensitive way to search, particularly if you're doing a systematic review where you want to be as sensitive as possible. So here we've got examples of floating subheadings, which is .fs in Ovid. So you've got AA.fs for adverse effects, as CI.fs for chemically induced. And it's exactly the same in Embase. You can just put .fs if you're in Ovid. The tripled linked subheadings is something particular for Embase, and it's most easy to do in embase.com. So this is where you have literally triple indexing. So you have the intervention, the adverse event, and the named adverse event. You can also search on them in Ovid, but you have to know what indexing terms you're searching for. So you could just look at the bottom of a record, see a triple indexing, and click on it, and it would take you to the results of a search for that triple indexing. To be honest, I don't use it very often for systematic reviews because I like floating my subheadings, and I've got Ovid here. I also said that there are search filters or search hedges, as they're called more so in America. And there are ones available to you to help you search for your harms data. And it's a different filter, however, depending whether you've got a drug intervention, a surgical intervention, or a medical device. The sensitivity of all the search filters currently stands at around 90%. It obviously varies though, depending, which has been increasing as reporting has started to improve. So this is the filter currently available for Ovid MEDLINE. As you can see, this is for drugs. So this relies heavily on terms such as side effect and adverse effect type terms, and also toxicity, tolerability, drug induced. So these are the drug terms that are really useful. Whereas this is the medical device search filter. And as you can see, very different terms. So you've got things about failure, Some devices are put in surgically, which is why you might want to consider post-operative complications, but also terms like loosen, breakage, untoward effect, equipment safety. So, and then the search filter that we developed for surgical procedures. I love this one because it's so simple and so short. So for a search filter. So here we're relying on more complications type terms, which is what you would generally use when talking about harms in surgery. So in summary, I recommend for 99% of the time that you'll need a separate search for your harms and your benefits. And they both need to be reported just as good as each other. So we always aim to be transparent and reproducible with our systematic reviews. And so don't just report the search strategy you did for your benefits. You also need to do the search strategy reported well for your harms as well. In general, we do need to search on generic and specific adverse events. A combination might be good. So if you're searching for cancer, you might want to use a combination of cancer terms with the generic harms terms. And lastly, a different approach will be needed depending on your type of intervention, because different terminology is used depending on whether you're looking for the adverse events of a drug, medical device, surgical procedure, or even a physical intervention, which there isn't currently a search filter for. So there is guidance out there. I've just included some references to the search filters. And you'll all be aware, I'm sure, of Chapter 19 in the Cochrane Handbook. I'd also like to do a little plug for the Cochrane Methods Adverse Effects Methods group. And we've got our own website and Twitter account if you'd like to follow us. Okay, thank you for listening.